Okay, so picture this. A patient comes into your office complaining about these really awful, recurring dizzy spells. They tell you their hearing in one ear seems to come and go, there's this constant roaring sound, and a weird sense of pressure. Now, if that pattern is ringing a bell, you are definitely on the right track. But here's the kicker. That patient has probably been dealing with this for years before getting a proper diagnosis. And this right here, this is the classic clinical puzzle. You've got these four distinct symptoms, but the real golden ticket, the clue that ties the whole thing together, is that they all happen consistently in the very same ear. It's a pattern, and once you see it, it's pretty hard to miss. But the thing is, historically, it has been missed a lot. For how long, you ask? Yep, you're seeing that right. The average delay from when a patient's symptoms first kick off to when they finally get a diagnosis of Meniere's disease is a staggering 2 to 4 years. That's one of the longest diagnostic delays in all of vestibular medicine. And as you can imagine, that delay has some pretty serious consequences for the patient. So let's frame this properly. We're calling this section the problem, a 2-year delay, because this isn't just some inconvenience. This is a critical window of time, a window where we could be intervening to preserve their hearing and their quality of life. So understanding what's at stake is absolutely the first step. Now, you might be thinking, well, this must be a really rare condition. But it's actually not. With a prevalence of 200 to 500 cases per 100,000 people, Meniere's is one of the most common, yet somehow most underdiagnosed vestibular disorders out there. It usually hits people in their 40s and 50s, right in the prime of their careers. So the odds are pretty high you're going to see this in your practice. And the stakes for that 2 to 4 year delay, they are incredibly high. For one, up to a third of cases can eventually spread to the other ear. And if it's just left untreated, the disease gets worse. After about 5 to 15 years, a lot of patients go into what's called a burnout phase. Now, the good news, if you can call it that, is that the crazy vertigo attacks might stop. But the terrible news, the price for that piece is often significant, permanent hearing loss. And that is exactly what we're trying to prevent. So what is actually happening inside the ear to cause this whole devastating cycle? To really get a handle on the symptoms, we've got to understand the mechanism. So let's zoom in and take a look right down at the microscopic level. So the main villain in the Ménière story is something called endolymphatic hydrops. Just think of the inner ear as this delicate, fluid-filled plumbing system. Well, in hydrops, one of those fluids, the endolymph, starts to build up. There's just too much of it. And it causes the whole system to swell up like an overinflated balloon. All that pressure, that's the root of the entire problem. Now here's the really fascinating part. This cycle explains why the symptoms come and go instead of being constant. So first, the pressure builds and builds, stretching out the parts of the inner ear that control hearing and balance. Then, bam, a rupture. A tiny tear in the membrane lets this potassium-rich fluid leak out and mix with the surrounding fluid. This basically short-circuits the delicate hair cells and triggers a violent vertigo attack. And then, eventually, the membrane heals, the fluid balance gets back to normal, and the attack goes away. Until the whole cycle starts all over again. Okay, so that's the complex science happening on the inside. But how do we spot it from the outside? Well, the solution starts with a simple, super memorable pattern. And I don't want you to think of this as just a list of symptoms. It's more like a clinical fingerprint for the disease. All right, here it is, the 4-part symptom tetrad. Number 1, spontaneous vertigo that lasts for a very specific amount of time, more than 20 minutes, but less than 12 hours. Number 2, hearing loss that comes and goes, especially in those low tones, and it has to be documented on a hearing test. 3, that annoying low-pitched roaring tinnitus. And 4, a feeling of fullness or pressure in the ear, which often gives the patient a heads up that an attack is coming. And what's the golden rule? Say it with me, all in the same ear. So if you can recognize that tetrad, you are most of the way there. It gives you a really strong clinical suspicion, what we call a probable diagnosis. But to get to a definite diagnosis, we need objective proof. So let's look at how the official 2015 Bárány Society criteria help us make that final leap. The difference between probable and definite Meniere's is absolutely crucial, and it all boils down to one thing. For probable, you need a couple of vertigo attacks plus those fluctuating ear symptoms. But to lock in that definite diagnosis, the rules get tighter. The vertigo has to be in that 20-minute to 12-hour window. And here's the key. You need an audiogram. You must have that test to prove there's a low-frequency hearing loss in the affected ear. I love this flowchart because it just makes the whole process so clear. Let's walk through it. You start here with the patient's story, the episodic vertigo and ear symptoms. If they've had 2 or more attacks that fit the time frame, you follow this path right here to the single most critical test, the pure tone audiogram. If that test shows that classic low-frequency hearing loss, boom, you've landed on a definite Méniere's diagnosis. If not, or if you haven't done the test yet, you're sitting in the probable box, and the next step is crystal clear. Get that hearing test ordered. And honestly, this quote right here sums up the whole explainer. If you take away only one thing today, let it be this. Ordering that audiogram is the single highest yield thing you can do. It takes you from just a suspicion to a certainty, and it is the key that unlocks effective management. It literally short-circuits years of delay.
Okay, I know what you're thinking. My patient's story doesn't fit that perfect textbook picture. And you know what? You're right. Clinical practice is never that clean and simple, is it? So what do we do when the history is just a little bit off?
Here is a super powerful clinical pearl for you. Just ask, how long does a typical attack last? Duration is a fantastic way to tell these conditions apart. If the vertigo is over in a few seconds, you should be thinking BPPV. If it's lasting for many hours or even days, and they have other migraine symptoms, start thinking about vestibular migraine. But that 20-minute to 12-hour window, that's the sweet spot for Ménière's disease.
So let's bring this all home. What is the single most important practice-changing thing you can start doing tomorrow for these patients?
It really is this simple. See the Tetrad, order the audiogram, shorten the delay. That's the mantra. First, train your eyes to recognize that 4-part symptom pattern. Second, the moment you suspect it, order that hearing test. And third, by doing just those 2 things, you will slash that diagnostic delay and get your patient on the right path to treatment and to preserving their hearing.
So now that we've nailed down how to recognize Ménière's, our next explainer is going to dig deep into telling it apart from all its mimics. We'll cover some key triage questions you can use in your history taking and take a look at how those audiogram patterns change over time.
Hey, thanks so much for watching this explainer. If you want to explore more topics on dizziness, vertigo, and imbalance, or get your hands on some great resources for both clinicians and patients, please head over to AustralianDizzinessClinics.com.